Because when we think about medical errors, one of the leading causes of medical errors is poor diagnosis. In other words, the doctor just didn't think of it, right? And that is just way too common when it comes to women presenting with actually really classic symptoms of menopause, is they just didn't think of it. So we need that in the differential diagnosis. We need prescribing hormone therapy to not be the end game, to not be menopause care. Menopause care is so much more than that. That's part of care, but it needs to plug into diagnostics and screenings and all the preventive health and chronic disease management as well. And when we think about all the emerging clinical guidelines that we're all beginning to follow, if you really look closely at them, we don't even have the infrastructure to support those guidelines adequately. So when we talk about menopause-informed care, we're talking about building the healthcare system out, building capacity in the healthcare system.
The information provided on this podcast for educational purposes only and is no intent nor should be used as a substitute for medical advice. Consult a licensed qualified medical physician for any issues concerning your health. Welcome to Taking Charge of My Cancer, the podcast where we empower with expert insights to help you live healthier, stronger, and more informed through every stage of life. Today, I'm delighted to welcome again Dr. Lisa Chacko, a board-certified primary care physician, menopause specialist, and nationally recognized advocate for transforming the way we think about women's health in midlife. Dr. Chacko is redefining how menopause care fits into modern healthcare through her innovative framework of menopause-informed care, an approach grounded in the belief that menopause care is a niche specialty, is primary care and a cornerstone of lifelong health. Her mission is to ensure that every woman has access to knowledgeable, evidence-based care during one of the most significant transitions in her life. She serves as an assistant professor at the University of Central Florida College of Medicine, courtesy faculty at the University of Florida College of Medicine, and collaborates with academic institutions, employers, and community organizations to advance education and improve women's health. She also advises industry leaders on how to better understand, communicate about, and design healthcare solutions for women in midlife. In addition, Dr. Chacko is the founder and medical director of Curate Medical, a menopause-informed virtual care practice serving women throughout Florida, where she helps patients navigate menopause with personalized and comprehensive care. In today's conversation, we'll explore what every woman and every healthcare provider should know about menopause, why this life stage deserves far more attention than is often received, how hormonal changes influence everything from bone and heart health to cognition and cancer survivorship, and what evidence-based strategies can help women thrive through midlife and beyond. So whatever you're approaching menopause, currently experiencing it, support a loved one, or caring for a woman as a healthcare professional, this episode is packed with practical insights and empowering information. So please join me to welcome Dr. Lisa Chacko to the podcast. So Dr. Chacko,
Thank you for having me.
Thank you so much for doing this. We're going part 2. So I really appreciate you taking the time to do this again with me.
Of course.
So what are you working on these days? So what's new? I'm excited to know all about it.
Yes, I'm doing a bunch of fun projects. I'll give you a glimpse into some of them. Of course, as you already mentioned, the academic work, teaching residents, I've been doing that and I will continue to do that. And those are primary care residents, and we learn about menopause and take care of patients there. And then my practice, which you mentioned, and that's all going well. And we have additional doctors and we're seeing patients. But in terms of other kind of bigger projects, because you know me, I am always thinking about how we can make this conversation bigger and really transform the healthcare system and design the future, not just react to the kind of poor status quo of today. So I'll give you 3 quick glimpses into projects I'm doing that I'm super excited about. One is that I'm currently writing an issue brief for SAMHSA, which is the division of the Department of Health and Human Services at a federal level that focuses on mental health. And we are writing about women's mental health and substance use at midlife, making policy recommendations and clinical recommendations that healthcare system leaders and policy leaders can implement so that we can really move the healthcare system forward for a very vulnerable group of people. That's one. Another project I'm working on is I was able to work with the Florida Medical Association to help lead and moderate and design a panel that's coming up next weekend at their annual meeting, where we are bringing together 4 additional top menopause doctors from the state of Florida. And we're going to be educating our colleagues across a ton of specialties, all meeting in person in Orlando, Florida next weekend. And so moderating that content and deciding what people need to know is very exciting. And then, of course, those panelists are all just brilliant physicians, women that I'm excited to work with. And then, the last one is kind of interesting. It's an industry, and I'm actually doing some work at an advisory capacity with Bayer Pharmaceuticals, because as people may or may not know, but I'm sure we'll get to, there's really interesting new medications on the market that are non-hormonal options for treating vasomotor symptoms and managing women through midlife and menopause. And so it's exciting to be a part of that and make sure that incredible drug developers have clinical minds thinking about how they communicate about these options to frontline healthcare providers.
That's super exciting. Now I see how you have the time to do all this and then the time to be with me. So I super appreciate it even more.
Thank you.
So you operate under the belief that menopause care is primary care. So what that means to you and why that's matter?
What I mean when I say menopause care is primary care is that I envision a future where your usual source of care understands menopause, that menopause care is basic. When I say menopause care is primary care, I am not in any way excluding any other medical specialty or allied health professional. In reality, we all know that sometimes it's actually your gynecologist that acts as your primary care doctor sometimes, or if you have a certain illness, it could be that your specialist is your primary point of contact in the healthcare system. But, so we're not trying to exclude other specialties, but really it's this vision that this is basic, that this is not so unique and special that somebody on your care team understands this process. So more specifically, when I say menopause care is primary care, what I'm saying is that ovarian physiology and pathophysiology belongs at the center of the practice of medicine, that expertise should not be siloed for the rest of your healthcare. I mean also that primary care is interdisciplinary. It represents the front line of medicine. It represents the front line of healthcare. It's an entry point. It guarantees access, but there can be pharmacists and nursing and physical therapy, and all kinds of people can be part of primary care. I envision that every member of the care team is menopause informed at the level that they need to be. They have some basic competency literacy commensurate with whatever their scope of service is. And frankly, I think when we say that menopause care is primary care, it helps to elevate other specialties to do what they do best. Our gynecology colleagues are so valuable, not just in the longitudinal continuous care they provide, but also their incredible procedural expertise and surgical expertise. And so when we make menopause care basic and push it into primary care, we also alleviate the system from these backlogs when we're treating this like it's a subspecialty of medicine, and it's not. So we can build capacity in the system in that way. The vision is that patients should be able to talk about menopause at their usual source of care, whatever that may be, and certainly still be referred in. And there's different levels of complexity, and subspecialty menopause clinics should always exist for those highly complex patients. But the end game that I envision with this menopause care is primary care mantra is that women have access to longitudinal care across their lifespan that understands that this is part of a journey, a healthcare journey that plays out over decades and decades and decades.
And this is amazing. And I feel this more just because I'm in that midlife stage myself. And it's amazing how right now my primary care is really great about working with me, but he has really not that much knowledge about what he's doing, but he's trusting me in like, okay, what about this? What about that? And he listens and he kind of work with me, and then he's about to retire. And I'm like, I need to find actually a primary care like you, like understand what stage of life I am. I don't need like the same person that saw me 20 years ago and I'm locally being very healthy all along. So I just really need you guys for a physical every year, and that was it, and nothing else, because I have the first one should be very healthy, but not anymore, right? I need somebody who understands these hormone situations that happen and everything that is going to be happening from now on. So I feel like we need a lot more people like you, Dr. Chacko, because it's amazing
Oh,
how it's not really like I'm looking around like who in my network has an idea of menopause. And then it is really not that many people out there. So I'm so glad that you're doing everything that you're doing right now to actually educate other healthcare providers so they can become more educated and then just continue their practice, but with this other piece of education and then that that help them to help patients to navigate through that.
yeah. The good news is I do think it's starting to change. I keep hearing stories from people that they went back to the doctor that a couple years ago was maybe a little bit dismissive, but this time around they seemed ready to talk. So I actually think we're in the middle of a change, but give it 10 years.
But we don't have 10 years, it needs to be now.
I know, I know.
So you develop a framework you call menopause-informed care. Can you walk us through what that looks like in practice?
Sure. I really think it's important that we distinguish between this idea of menopause care and menopause informed care. So that's why I kind of coined that term. I still use the term menopause care. We were just using it in our last set of questions, right? When I said menopause care is primary care. But menopause informed care lets us create a much bigger lens and scope. And I would propose that menopause informed care is the new standard of care for women and that we need to implement this system wide over time. So it's really a population health approach to healthcare design and thinking about an entire ecosystem of care that understands the female body, that understands the role of the ovary in long-term health. So again, my answer to this question, when you say, what does this encompass, will in some ways mirror my answer to the prior question. But again, we need to envision a system in which everybody on your care team understands the female body and understands ovarian health across the lifespan. We need to envision a healthcare system where every doctor that you see has a broad differential diagnosis for whatever specialty they're in, whatever symptom you present with, and that ovarian physiology and menopause physiology is in that differential, right? Because when we think about medical errors, one of the leading causes of medical errors is poor diagnosis. In other words, the doctor just didn't think of it, right? And that is just way too common when it comes to women presenting with actually really classic symptoms of menopause is they just didn't think of it. So we need that in the differential diagnosis. We need prescribing hormone therapy to not be the end game, to not be menopause care. Menopause care is so much more than that. That's part of care, but it needs to plug into diagnostics and screenings and all the preventive health and chronic disease management as well. And when we think about all the emerging clinical guidelines that we're all beginning to follow, if you really look closely at them, we don't even have the infrastructure to support those guidelines adequately. So when we talk about menopause informed care, we're talking about building the healthcare system out, building capacity in the healthcare system. So, for example, in the breast cancer space and breast cancer risk space, we know that many women who have elevated risk of breast cancer could be, should be, ought to be considering breast MRIs as part of their screening modality. Can they access those? How much do they cost? And also, we know that there are fast MRI protocols now. It's a new kind of quicker way to do those MRI screenings. Can you get them? Are all the academic health systems even offering those? What's the price point? And there's many examples like that where if you actually look at the science and the guidelines, we can articulate and describe what the standard of care is. But if I sit before my patient and go try to make it happen, there's all kinds of barriers because we don't have the infrastructure. So menopause informed care means we have a system that actually works for the guidelines that we want to follow, DEXAs, FRAC scores, all of the rest, cardiovascular health, metabolic health. So there's a lot of opportunity because the bar is pretty low, but I'm an optimist. And so I embrace the idea that this opportunity exists. And I think there's a ton of us that are motivated and want to build for the future.
That's unbelievable. We need that so much. So if you're looking at menopause informed lens change, how should you kind of approach that primary care visit, right? So I'm your patient, I'm coming to you for my first primary care visits. So what lens is different from my other primary care that I usually see on a regular basis?
What would be different? What would feel different in a menopause-informed primary care setting? First of all, you don't, as a patient, have to make an arbitrary decision. It's time or it's not time to seek menopause care. This is just your doctor. You can ask a question about it when you're 22. You can ask a question about it when you're 35. And also, your doctor should proactively be bringing this up by your late 30s if it hasn't come up naturally for that anticipatory guidance, just like we do with puberty. If we have young people coming into our clinics and they're getting to that age, 11, 12, we lead the conversation. Hey, puberty's coming. These are the things that could happen. We have options. We can support you. Never hesitate to reach out. So, one big difference in menopause-informed primary care is that it's just the water that you're swimming in. There's not a dividing line. There's not a certain level of suffering or a certain age that's required to have that conversation. I think that's one huge difference. Anticipatory, longitudinal care. Two other differences, I would say. One is the integration with chronic disease management. This idea that menopause care is like up and over here as some kind of like add-on niche, I don't know, wellness or longevity play is absurd. People are real people. They have medical histories. They have other stuff going on. They have other concerns. Like this should all be woven together and not be considered as so separate and unique and special. It's part of your healthcare. So I think that dovetailing with all of your other concerns would be another advantage to menopause-informed primary care. And the last one goes back to that idea of differential diagnosis. We do certainly have patients show up in their regular primary care clinic or their regular gynecology clinic, and they show up with what we call it a chief complaint, right? They show up with a number one concern, I want to talk about menopause. But in reality, people show up in clinics for all kinds of reasons. They might show up for a urinary tract infection. They might show up with abnormal bleeding. They might show up with weight gain. They might show up with whatever they want to show up with. And the nice thing about menopause-informed primary care is like the patient doesn't have to know. They can come, and then the provider, the doctor, the clinician, whoever, whatever we're going to call that person or that team, can filter that through their menopause-informed lens to consider the role that this hormonal transition might be playing in their patient's presentation. It takes the onus off the patient to know and direct their own care.
That's great. Many women still fear hormone therapy because of cancer. So what does the current evidence actually show in that regard?
In the simplest terms, what I would say to that question, this question of fearing hormone therapy due to cancer risk, is we know now that the majority of that fear is not well-founded. And I would argue that a lot of that fear, my observation, is no longer prevalent in the population. I actually don't hear that very often. Frankly, sometimes I almost hear the opposite, where people assume there's zero risks to anything and it's all good all the time. But I think we could just reassure women that for the vast majority of women, the benefits far outweigh the risks. But obviously, you need that personal one-on-one conversation about your specific risks and how they apply to any decisions that you would make.
That's very good. And I'm agree with you. I am still hearing some fear about that. And I'm still kind of, again, guiding patients back into, no, this is really not true anymore. This is a great evidence, great books out there that can kind of really help them to sort that if they're a candidate for, of course, discussing with their medical oncologist or gynecologist or primary care or one of the physicians just to make sure is that the right thing for them. But I'm agree with you. I don't hear that, but I'm still hearing some of that. How do you personalize hormone therapy decisions, particularly for women with a family history of breast cancer, as well as a personal history of breast cancer?
So how do we personalize hormone therapy decisions for all patients? I mean, sort of every healthcare decision should be personalized, which means applied to your specific goals, your risk tolerance, your actual risk, your fears, your biases. I always tell people, like, you're allowed to have irrational thoughts. You're allowed to have magical thinking. Like, we can weave that into our decision making. So there's all kinds of ways to personalize decisions. Now, with regard to a family history of breast cancer, of course, we do all need to collectively dispel the myth that a family history of breast cancer is automatically a contraindication to using estrogen therapy. That's not true. So that's something we can kind of just make sure the memo is out. It doesn't mean that that person's concerns are not valid. They might have elevated risk of breast cancer themselves due to that family history, and that personal risk should be assessed, quantified, and then that quantified risk can be brought into their decision-making process. But family history, not a contraindication. So we just need to keep making sure people, at least that basic fact is out. And then, in that specific case of family history, that would be one of several scenarios where, well, first of all, we calculate breast cancer risk on every single patient. That would go back to a new standard of care and menopause-informed care. Like every single woman, that is a guideline, should have that risk calculated. But for patients who have elevated risk, then we discuss what the risk threshold is, whether they're a candidate, are there ways to use hormone therapy that are more breast neutral, or lower risk for breast density, for example. We look at other variables, history of what their mammograms have showed in the past, what their biopsy have shown in the past. So there's a whole assessment that has to be done that's really meant to happen in a one-on-one setting. And then for personal history of breast cancer, that's really, really tricky. What we mostly want to try to do is manage folks non-hormonally. And there's so many good options. And so we often have great success with non-hormonal options.
Okay, very good. And then for women who can or choose not to take hormones, you talk about some safe alternatives. You want to kind of speak more about what safe alternatives that could be?
Yeah, I think the two big buckets worth mentioning would be for the two kind of most known symptoms, for the sexual and genital and urinary type symptoms. Of course, this is another one we have to make sure the memo got out, that those women can still use a vaginal estrogen product. And so they can use that localized hormone product to treat those symptoms. Check, done. Tell everybody, moving on. This is what I'm saying. Like the things we know we need to implement and move on. So that is one of them. Okay. I think we're kind of there, maybe kind of there, maybe, I'm not sure. And then for vasomotor symptoms, we have these newer drugs that they interact with the hypothalamus, which is part of the brain. And it's the part of the brain that regulates our temperature. So, science gives us more options. So we figured out what causes the hot flashes, and it's this little thermostat in your brain. And lo and behold, changing estrogen levels toggle that thermostat all over the place. And that's why estrogen therapy works to manage that symptom. But now we have new medications that target, it's called the NK1 and NK3 receptors, and can have a similar benefit with quick response within the first couple of weeks, work extraordinarily well. This is good news, right? We're beating the drum on menopause-informed care, and okay, it's 2026. Finally, we have drugs that were specifically designed for and approved for that indication. And I only expect this to keep going.
Is that the Viosa? Is that one of those?
For brand names, there's two medications. One of them is Viosa and the other one is Linquet. And they are similar, but a little bit different. Linquet acts at 2 receptors. Viosa acts at 1 receptor. So Linquet potentially has more impact on sleep, which can be helpful. And there's a few other differences with regard to lab monitoring and whatnot, but they're both good options.
Awesome. Now, this is another question I have just comes into my head is, sometimes I hear a lot about some women just get prescribed antidepressants to sleep better and to try to control these symptoms. Is these new medications an antidepressant kind or not? Totally different?
Not at all. So until these two medications came on the market truly within the past year or so, all of the non-hormonal medications that we had on the list, I don't want to say it was sort of like a waste bucket, and I'm not going to say that they actually couldn't be efficacious and had data to support them, but none of them were designed for the indication of vasomotor symptoms. None of them were approved for that indication. They were all off-label and with variable efficacy, to be frank. And so there's SSRIs and SNRIs, which are types of antidepressants that have been used to treat vasomotor symptoms in the past. And it still could be reasonable to consider that in certain scenarios for that indication, but we're moving beyond that world. Now we have medications specifically for that. The last comment on the antidepressant piece is, the other thing you hear with antidepressants is just when you go to a doctor who's not menopause informed and you're 48 and you say, my mood has changed, I don't know why, instead of thinking, this is pretty obvious, let me ask a few follow-up questions, this is likely related to her menopause transition, I'm going to rule out anything else. They don't have that thought. And they're like, you are clinically depressed, here's an antidepressant. Now, people can use antidepressants and they can be part of midlife healthcare, but it's that lack of precision and thought that I think has led many women to feel, and the evidence to support, and if you look at the prescription data, that they're just being handed out like candy, quite literally without another thought. But they're great medications. They can play an important role. So we don't want to stigmatize those drugs or make people feel that they should be avoided at all costs. It's just you hopefully are working with a discerning clinician who can decide when, how, where, and be very intentional about any medication that would be prescribed.
That's a great explanation because I hear that a lot. Like, I hear exactly what you just say to me all the time. Like, they come and present with, like, I'm really having a hard time sleeping, hot flashes, hormone changes. And then we know already what's going on. But you're right. The physician is like, oh, what is the pill again? Here we go. You just take that, or just all on your head, right? You'll be better. You're just stressed out because you're, midlife and the kids are leaving the house, and it's all blame into is in our heads, and it is not real. So this is something as well that I'm like totally encourage women to like, no, this is not what it is. Look at this, listen to this episode from the podcast, or go read this book and look at this, evidence based, and go back to your primary and then actually bring this information to them and inform, and just kind of like, look, what about these other situations, right? Is that something for us to consider?
Yeah, these stories are so discouraging, especially when we realize how common they are. Because, it's almost like every single patient that comes to our practice has that story. And like the way I deal with that feeling of discouragement after hearing the story so many times is this, it goes back to where we started the interview, is like, I sort of refuse to be focused on the status quo anymore. It's so uninspiring. I am in the future. Like, I think we need to be dreaming up a future that is very different, because honestly, like, small iterations away from where we are now is not enough. It is not enough. So it's painful to hear those stories. I know they're happening every day. I'm kind of like toxically optimistic, not really, but because I feel that if you're not optimistic, you won't engage. And if you won't engage, you won't be playing a role. And we need to be really thinking about how we want the healthcare system to look 20 years from now, and start building that right now.
Yeah. And one thing that I'm super excited like about you in particular, or like healthcare providers like you that are involved with teaching medical students, right? Because then you're teaching the medical students and the future primary cares already this concept that for them they're gonna
Yes.
like, this is part of like doing an eye.
It's so basic. Yeah, it's so, then they think it's so basic. It's no big deal. And like, yes, there's all these stressors. They're still busy. The healthcare system's crazy. We need to fix it all. But I call it, they grow up with it. They learned it at home. When they learned it in residency and they learned it in medical school, that's why I know it sounded sad when I said, give me 10 years, but 10 years is nothing. 10 years is fast, right? But if we can penetrate the med schools and the residencies, done.
Yeah. Yeah. I think it's
Just give it
give it some time. I think it's very similar in my field, like, how popular is oncology rehab. It really wasn't really that popular that many years ago. I mean, through the APTA, we just become a board certified specialist in oncology just 6 years ago, when we have like sports medicine, women's health, geriatrics, and some other specialties for so many years before. So I'm actually talking as well with the UF faculty and PT, like, how are we adding this oncology? I know it's like, medical school, you're learning so many things and a little bit of everything to try to fit everything in the career, but we need to start to bring this oncology terminology, chemotherapy, in the pharmacology classroom, radiation. I mean, we got to start getting this information to the students, because when they come here for internships, they're totally like lost. This is totally new to them versus when injected into their curriculum. And I actually was just teaching a class last week, which was great. That was the first time we're doing it where we actually adding that in their curriculum. So this is no news to them. So next year when I teach them again another class, it's like, okay. And when they come here as an intern, it's like, you already know these things. So it makes really a big difference.
That's a great example. Yeah, I do think at the end of the day, education is the number one strategy among many other important strategies, but it's going to be the most impactful long term.
Absolutely. So is this anything empowered message you want women to take away about menopause and cancer risks? What will be that?
You were mentioning before how you empower women to go to their appointments and sort of demand more answers. And I had to tell you that the fact that we have to do that breaks my heart. The fact that empowerment looks like arming women to go argue with their doctor. Again, my head's in the future. I don't want that to be how we define empowerment. I want empowerment to be having access to excellent healthcare so you can go live your life and be empowered in your real life the way that you want to be. But I won't avoid your question. I think a couple empowering things I could share with people are like, hey, there's a lot of us like really working on this. And I want that to feel empowering to people. And also you can work on it. What field are you in? You want to work in healthcare? Everyone has a role to play. So I think there's an empowering feeling in this idea that like, we will be doing this. We are doing this. We are going to change the healthcare system and everyone can play a role in that. And with specific to menopause, I do think our current narratives can continue to evolve. We're in a cool moment. Certainly the menopause narrative has evolved a lot over the past 5 years. Over the past 10, and it will over the next 5 to 10, even further. I think the current narrative is still quite reactive. It's still very much grounded in the storyline of like, I didn't see it coming. So I look forward to an empowered world in which everyone sees it coming, because you've known since you were 20 about all of this stuff, right? Because we've all been talking about it. And it's not this like elusive, new, sexy topic that's scary. And some people know about it and some people don't. It's just, again, like more basic. That's what I want to feel empowering to people. So I love talking to even younger women who have questions, because that feels empowering when you're navigating decades of your life knowing what's coming. I think the question about cancer risk is a little bit different. To empower a woman around her cancer risk, I had several risk conversations today with patients. Risk is not a fun thing for people to talk about. It's just like one of those words where it inherently feels risky. I don't know to talk about risk. Gary, yeah. And I think most people would feel empowered with regard to their cancer risk if they had the peace of mind to know that they had done everything that they could do to live their healthiest life and that they had access to the right services when it was appropriate. And so to some extent, this is me circling everything back to, we just need to build better healthcare. It's our job. It's not their job. But, if you know that you had access to great care and you had access to great screenings and you had access to the appropriate advice and no one was giving you the wrong medical advice and you were living your healthiest lifestyle, there's risk out there. But, that's empowering to know that you do what you can do and you get the care that you can get in terms of your risk, and that it's somebody's job to be thinking about that on your behalf, and that you don't just have to kind of worry about it alone and not really know, like, am I supposed to be doing something different? I want people to have that confidence that only really comes from having access to amazing healthcare.
Yeah, that's a very great to put it. And I think I love two things you just say. One is this conversation needs to start happening at age 20. I heard so many things about, why are we thinking about osteoporosis when we're 65? What are we doing a DEXA scan when you're 65, right? When it's just a little bit too late for that, instead of start at a lot younger age. And then, wow, I'm start having some issues with osteopenia. I need to start really work on my skeletal muscle mass and work on the strength training so I can feed that bone and I can prevent some of these things, right? So
Yeah.
like,
Yeah. And to talk about it earlier, there's a really lovely young woman in my gym, and she's under 30, and she heard what I work on. So then she'll come up to me and ask me questions. And I told her, I was like, listen, you are literally putting money in the bank right now. You're lifting weights. She's building her bone density. That's like her bone 401k. She's shoving it away. I'm like, just keep putting it away, keep putting it away. Because that bone density conversation in a younger woman is so different than in an older woman. Right? So talk about empowering. I mean, that woman is empowered because she's literally doing what she can do at the right time to set herself up for success later. That's a window of opportunity. She's got it. And now she knows she's doing it. And so she feels reassured.
Exactly. That's a great example of how we need to start to shift things, and then looking as well into this preventive, right? Which is a lot of longevity noise out there on the social media as well. But again, all this happen. Again, and longevity is no like, let's do Botox and let's do plastic surgery, which is great for people who wants to do it. But it is, what can I do with my life from the beginning to be as healthy as I can be, so I don't have to deal with this? I often tell my patients, and even my students, is like, every cancer patients I came across, every one of them has only become healthier after their diagnosis. Why do we have to wait until we come across a diagnosis like that to become healthier? Why we are not healthier all along? So hopefully we will just prevent some of that, and not just cancer, but any metabolic disease, right? Any chronic disease, diabetes, obesity, whatever it is. So I think that it's really, but again, I don't hear from anybody who improve their activity, the nutrition, how they take care of their bodies after work, versus like, why are we waiting this long to do this instead of really getting all that? So it's fun too for my young students, right, who are like, listen, you hear this all the time. You better start putting this in practice. And it's nice for them to start changing the way they live just for being here and hear this all the time. It's like, oh, I better start going to the gym. I better start doing some more lifting. I better start modifying my nutrition. And so it's kind of nice to have the opportunity to do that.
That's great. Yeah, lifestyle is that virtuous cycle, right? The healthier lifestyle, the better you feel, the more empowered you feel because you're doing what you can do. Absolutely. I think the younger generation is more plugged into lifestyle. They don't even drink as much alcohol. They're all in the gym. So, it's interesting. I'm keep my eye on them.
Yeah, you know what I heard the other day in a podcast, that the people who is drinking more alcohol is midlife women.
Well, I told you I'm writing an issue brief for our federal government on this topic, and that is 100% true. There is biological susceptibility because what we know in the female brain is, so this could be premenstrual luteal phase. The hormonal fluctuation interacts with the brain, creates a milieu, an emotional milieu, and then there's no access to healthcare. Nobody's helping me. I can't manage my symptoms. So I'm going to turn to manage my symptoms through, let's say, alcohol, alleviate the anxiety, whatever it may be. And so that is one biological phenomenon specific to women, and it's called negative reinforcement. The idea of reaching for substances, not just because you're not looking for a good time, you're actually trying to take care of a symptom. That's why women reach for substances many, many times. And then the second biological phenomenon is called the telescoping effect. And so what the data shows is, if you take sort of on average male versus female, when a female starts using a substance, she tends to go quicker and escalate quicker from use to misuse to abuse to disorder. And so there is a well-documented, not only biological mechanism for substance use at midlife and during menopause, but there's this cycle. And then unfortunately, you may have heard me say this before, but I refer to alcohol as menopause in a bottle, because unfortunately and paradoxically, when you reach for alcohol to help you with your, I always say the classic story is this: late 30s, early 40s, got a job, maybe got some people you're taking care of at your house, and perimenopause is setting in, but nobody really notices that. You're tired, you get home from work, you open the bottle of wine, you pour the glass, you're cooking dinner. Okay, I'm feeling a little bit better. Let's get the family going. Okay, well, now it's a few months later. Now it's 2 glasses of wine. Okay, now actually I just went ahead and finished the bottle. And next thing you know, this woman is in a spiral, never like florid addiction per se. But what's happening is now that alcohol is worsening her sleep. It's worsening her anxiety. It's worsening her night sweats. It's worsening her fatigue. It's worsening her weight gain. It's worsening her libido. And so it just spirals out of control. So that piece, and since we're on a cancer podcast, I think it's worth mentioning that, alcohol increases your risk of breast cancer. And we do not have enough public awareness about that fact. So when we talk about fear and hormone therapy, honestly, I'm actually not a big believer in fear as like a motivator, but I think a little bit more fear around cancer and alcohol would be appropriate in the general population.
Absolutely. Yep. Yeah, totally agree. That's great. That's awesome. So glad that I mentioned that. So
Yeah.
this is excited. I cannot wait
Yeah.
to hear the results of that meeting. Cannot wait to.
Well, we could do another interview just on substance use and midlife because by the time I'm done writing this brief, I am going to be an expert.
Awesome. I would love to hear that. Dr. Chacko, you've been really amazing as always. So thank you again for not just being part of this, but really being part of changing the way that healthcare move on in this, area now, 2026. And I think it's a lot of noise happening, which is exciting. And I'm glad that somebody like you is really doing things from like the federal standpoint to really change the way that things are because it's about time for those changes to happen.
We
So
need to think bigger. And thank you, Durley, because you have displayed an incredible amount of consistency with this podcast. And I think anybody who has a passion project and has consistency deserves a lot of recognition. And also you have a lot of patience as I rescheduled this podcast maybe 42 times. And so, a lot of respect for you for
thank
dealing
you.
with people like me.
No, I get it. And again, I know everyone in there that I've been able to approach. I mean, everyone really work extra to make a difference. And I know we have a lot of things going on. Is like you're doing a thousand things happening. And this is without even thinking about your personal life and your kids and what's going on with you. So I really appreciate you taking the time to actually have this with me and schedule things and things get crazy. So I appreciate the time as well. So that was fun. So thank you again.
Thank you.
And
Thank
then
you so much.
you have a great rest of the afternoon.
All right. Bye.
Bye. Thank you so much for listening to the latest episode of Taking Charge of My Cancer podcast. If you have not already, feel free to share this with more people so they can benefit from this information. If you would like to connect with me, see the information on the podcast description. See you later.